Hello, I'm Anita Nevius-Wallace here at the 2016 annual meeting of the American Academy of Ophthalmology with Dr. Arun Gulani of Jacksonville, Florida. Welcome, Arun.
Thank you for having me, Anita. It's been a real pleasure to be part of the one. This segment we're going to devote on keratoconus and my approach to keratoconus, again, being based on the mindset. I want people to think outside the cone.
I like that.
They have to think of keratoconus as a refractive surgery. Don't even call it keratoconus. Just break it into the 5S system that I talk about. It's just a cornea with a high keratometry, thin cornea, astigmatism in most cases, possibly myopia, sometimes hyperopia. If you think of it that way.
And irregular astigmatism.
Exactly. So my point is, if you break it down into these pieces, it's no longer the giant called keratoconus and you think of transplants and hard contacts.
But the irregular astigmatism is still the chief stumbling block.
Yes, but what has surprised me again of having done these cases is it is correctable in many cases, again, refractively. So the point in these cases is keratoconus, if you look at in my 5S system, if it's stable, patients over 40, more or less naturally cross-linked, and nowadays you can even cross-link or stabilize, but more or less natural over the age of 40, they have refractive errors and refractively proven to be stable.
Yes.
Now, you have so many more modalities. You can correct their cornea with intacts, which are directionally done. You can do single, paired intacts, steep axis, and play with the astigmatism in that direction and make it what I call measurable and sensible astigmatism. And we can show them in slides in the near future. Then you can put in phakic implants in these patients, again, if they're stable. You can put in an ICL in these patients if they're high myopic and stable cornea. You can follow up with a laser PRK for minimal astigmatism on these patients because astigmatism removes the least amount of tissue in laser PRK mode.
Are you combining with your intacts, or are you using CK to shrink and centralize the cone?
CK can surely be used along with the intacts, and I think you have shown this on many, many occasions, and it does work, and it's a nice combination to have. And that's where, again, when you look at keratoconus as a refractive surgery, look at the armamentarium we have today. You can do laser PRK, of course, in controlled cases. You can do intacts, and many ways of doing intacts. You can do intacts with CK. You can do intacts with ICL. You can plan their cataract surgery with toric lenses.
But you would not do those as a single procedure, would you?
Single, in those cases, that is directly emmetropic on measurement in some form and stable on all measurements, like it's sensible cornea, again, I call it. If it's not, then you first do what I call the outside-in technique. You stabilize the cornea. And then once you stabilize the cornea where you can measure it, do a proper IOL master A scan, now you go in to the eye with all the accuracy and you come out emmetropic. Similarly, outside-in technique and inside-out in these cases, I've had patients who've been sent to me with excellent surgery done, but it's keratoconic and the patient had a hyperopic outcome, which is unhappy for distance and near. Will you go inside the eye, do a piggyback lens, if you can exchange the lens, make the patient myopic, then do a laser myopic astigmatism treatment. You now decrease the keratometry, corrected the scar, expanded the optical zone, and brought the patient to emmetropia.
How much concern do you have about thinning an already ectatic cornea with a tissue removal procedure?
Sure. Again, laser PRK, if you're treating astigmatism, you're talking about 16 to 20 microns, given the epithelium itself is 50 to 60 microns, and most of these patients are over the age of 45. I think it's pretty safe. Once again, we have to look at their past history. If they're stable on refraction over the past 5 years, there itself is an indication that you can proceed.
Would you do a transepithelial treatment?
I prefer always manual epithelial removal. The reason for this is, again, over the decades I've seen in my own experience, when many keratoconus patients have scars, it's literally like a paper napkin waiting for you to pick up under the epithelium.
Really?
I don't want to miss that opportunity. So I insist on manual epithelial removal because, again, like our scar video that we did last time for one, you can actually pick up where the scar is on or in cornea and lift off the scar.
But in that case, don't you need to allow it to heal and then remeasure to know what the particulars of the PRK should be?
Yes, but again, the scar was refractively stable. So in that case, it was more of an opacity, not a refractive insult. So that's where, again, the refraction is so important to me. If the scar was part of the refraction, different topic. If the scar was just an insult acting somewhere where we want crystal clear vision despite the cone, then it's just something to be lifted off.
And how do you distinguish whether the scar is refractively relevant or not?
Because when you're refracting these patients, let's say one is their cone, which is giving them irregular refraction. Second will be the fact that you just can't see through the center as clearly, like a PRK haze, if you may, as we've seen before. But if you see that these patients are refractively clear, many a times under the epithelium, you will find this very soft cellophane tissue kind of napkin scar in keratoconus patients in particular.
Well, that is fascinating.
Absolutely.
Thank you so much for being with us.
Thank you again.